With anything, as you can note, risk is involved, and that's what Dr. Jonathan Myers is going to talk about.
Hello, and good afternoon. I'm John Myers. It's great to have you folks here today. I'd like to say how much I appreciate everyone coming to this conference. It's really exciting to have you all here. I'm going to talk a little bit about risk and risk assessment and lead from there into how we consider risk in glaucoma. As George alluded to, risks are inherent to all activities. I mean, there's the risk that you may fall asleep in the next 15 minutes. We'll quantify that at the end of this. But it's hard to quantify some risks. I mean, some things can look very auspicious. You know, the setting off of a ship on its maiden voyage. But, you know, Monday morning quarterbacking, it may turn out that there is a greater risk than anyone ever could have appreciated or foreseen. That's hard. How much would you pay for tiger insurance in New York City? You know this old joke, guys walking in Manhattan, he sees a street vendor with a bunch of aerosol cans, says, you know, what's in the can? This guy says, tiger repellent. Guy thinks a second, says, hey, there's no tigers in New York City, and the vendor says, see how well it works? So how do you price something that important a product? What price do you put on a product like that? Well, it can get complicated. Think about measles, mumps, and rubella. You know, all children have to get these vaccines or they can't go to school, and they have to go to school, so essentially they have to have the vaccines. What's your risk of infection with MMR, either any one of these three in 2008? 2 in 1 million. Now, that risk is that low entirely because we all get vaccinated. But for the single person thinking about this, they might mistakenly conclude, that's not worth much money. Well, compare it to the risk of a tiger attack in New York City. In 2010, what was the risk of a tiger attack, according to my best understanding? Well, it was about 1. 1 in about 10 million people, maybe 12 million people in New York. So it's different. It's worse than measles, mumps, and rubella. I mean, measles, mumps, and rubella are worse, but actually people do get attacked. But when we consider risks, you have to consider everything in its own context. The guy who got attacked was keeping a tiger in his apartment, and that may have increased his risk of a tiger attack. And this is Ming the tiger in 2003, when Ming was just a cute and cuddly thing. But by 2010, Ming was a little bigger, and things were a little more serious, both for Antoine and for Ming, who both survived the event. There's a famous quote often attributed to Mark Twain, and this quote is actually Mark Twain's. And as a subset of this quote, he mentions Disraeli said, there are 3 kinds of lies, damn lies, and statistics. Now, I'm going to talk about statistics. But actually, Twain ascribes that to Disraeli, but it's actually probably from an 1895 text by a guy named Courtney. So it's always hard to ascribe quotes. It gets pretty complicated 100 years later. We can consider risks a lot of ways, but we have to consider how we consider risks to understand that, which starts to sound like Rumsfeld's famous quote that we have known and unknown unknowns, which gets complicated. So first let's talk about what an absolute risk is and a relative risk. So the absolute risk, I don't mean an absolute risk as in it's absolutely impossible. I mean more absolute is just the fundamental risk, not taking into account anything but the exact situation. So if someone says to you, the odds are 1 in a million, and they mean that, 1 in a million times this happens in a given year, that means that for about 310 people in America, which has about 310 million people, it doesn't seem that rare because those 310 people had it happen to them. So the absolute risk is the odds, just the straight odds of it happening. For that person, again, Monday morning quarterbacking, who's been hit by lightning, 1 in a million, as they might say, it does not seem like it was a 1 in a million risk. For them, it seems like it was a 1 in 1 risk. Now, a relative risk is the risk of something in comparison to something else, the relative risk. So someone might say, you know, you're 50% more likely to get a toothache if you suck on lollipops all day. That may be true, but it begs the question, you know, 50% of what? So let me ask that question in a different way. Which would you pay more for? Which would you rather have? Something that decreases someone's risk of a heart attack by 80%? Or something that decreases it by 50%? Or something that decreases someone's risk by 18%? Seems like an easy question, right? Well, let me make it more complicated. Because there are so many people with heart disease, it's relatively easy to do studies on lots of people with heart disease if one invests a lot of money, which the National Institute of Health does. And based on a lot of very large studies with hundreds of thousands of people, they can really quantify a person's risk based on the factors you see on the screen. Key drivers are age, sex, smoking, cholesterol, and blood pressure. If you know those risks, you can really say what your risk is of having a heart attack or dying from a heart attack in the next 10 years. Here are real examples based on those numbers. The calculator. A 45-year-old gentleman who's a smoker but has good cholesterol and good blood pressure, his risk in the next 10 years of a major heart attack or death from cardiac disease is about 5 in 100, 5%. That's the absolute risk. So the same guy decides to stop smoking because he does the calculation, doesn't like the odds. He lowers his risk from 5 out of 100 to 1 out of 100. That would be an 80% reduction in risk, 80% relative risk reduction. Here are 100 people who all happen to be 45-year-old smokers, okay, with good blood pressure and good cholesterol. In 10 years, 5 of them, shown on the bottom right, would have had heart attacks or died. But because they all quit smoking, 4 of them were saved, an 80% risk reduction, okay? But 1 still dies. What about a 55-year-old smoker who does have high blood pressure that's not quite controlled and also has high cholesterol? His risk is a whopping 30 out of 100 of having a major heart attack or dying from heart disease in 10 years. This gentleman does the risk calculator, worries about it, and quits smoking. His risk drops to 15 in 100. That's a 50% reduction in his risk. And it looks like this. A lot of faces down there. All of them would have died in the first scenario or had a heart attack. But in the second scenario where the gentleman quit smoking, half of those that would have had the heart attack, wind up saved. 50% reduction in risk. But in this case, 15 smiley faces. And then the 65-year-old smoker with high cholesterol, high blood pressure, treated, 28 out of 100 risk in 10 years. You say, well, isn't that odd that the risk of the heart attack is less in a 65-year-old with the same numbers than in a 55-year-old? That's because, unfortunately, 65-year-olds die from other things and it cuts back. So if this person stopped smoking, they only reduced their risk of a heart attack or death by 5 out of 28, an 18% decrease in risk. So those are 3 concrete examples where you have 80%, 50%, or 18% reduction in the relative risk with different numbers. And here just summarizes all of that on the slide. So if you say with the 45-year-old smoker, remember it was 5 going down to 1 if he quit smoking who were affected by a heart attack, that 4 out of 100 were saved. Sometimes we talk about the number needed to treat. In this case, the treatment was quitting smoking, and the number needed to treat was 25. Why? Because for every 25 people in this example who quit smoking, 1 is saved the deleterious outcome, the very bad outcome of a heart attack or death. And you can see the 55-year-old smoker who quit smoking has 15 out of 100 people were saved, 100 people who quit smoking, which is a number needed to treat of 6.7, meaning that for every 6 people, 6.5 who quit smoking, 1 of them is being saved a very bad outcome. And then you see the 65-year-old, the number needed to treat is actually higher, 20. So there are a lot of different things here. There's the question of the relative reduction of risk, which may be very high, but if your own risk is not very high, that relative reduction doesn't mean as much. And then there's the related but not the same question as to how many people have to undergo a treatment or an intervention in order to actually have a positive effect. The higher that number is, the more resources are invested, the more trouble you're taking to save someone. So the relative risk is most valuable for any of us to know if our risk of something is relatively large. If my risk is 1 in a million of slipping and falling, I'm not going to pay you much for a rug that cuts that risk to 0.7 out of a million. On the other hand, if I'm president of the United States and I'm thinking in my mind that I have 310 million people in the United States, even small risks, when reduced, can yield meaningful outcomes. For example, in America, if you wear a seatbelt, you'll cut your risk of dying in a motor vehicle crash by about 50%. Now, your risk this year as an American of having death by auto crash is about 1 in 10,000. That's for 1 year. So you might conclude erroneously that it isn't worth wearing a seatbelt. But In America, each year more than 30,000 people die in auto crashes. In fact, the number is down to the low 30,000s. If we go back just 20 years, it was up over 50,000. Very, very many people in America die in car crashes. So as a society, if we all use seatbelts, we save tens of thousands of lives. Relative and absolute risk, two very different things. When we think about glaucoma, we can talk about relative risk too. For most patients who have glaucoma or ocular hypertension, for every 1 point average reduction in eye pressure, in other words, a pressure of 24 versus 25, you reduced your relative risk of getting worse by 10%. If we manage to lower your eye pressure by 5 points, you reduce your risk by almost 50%. But again, 50% of what? Are there any tigers here? Do you have a tiger in your family history? Are you sleeping with a tiger? Is your eye already severely affected by glaucoma, increasing your risk? So if you have ocular hypertension, to use some real numbers, your risk of getting worse in 5 years, on average, is about 10%. That means if we drop your pressure by 5 points, your risk would be cut in half. So your absolute risk would be about 5%. This is a little bit like that first smoker I showed you. So the intervention dropped your risk from 10% to 5%. With low-tension glaucoma, which in one study showed a progression rate of 35% in the untreated patients over 7 years, a treatment that dropped the pressure by 5 points, reduced the risk by 50%, would be a 17% risk. And you can see for early glaucoma, which in one study done in Europe showed a 62% rate of worsening over 6 years in the patients who weren't treated, a treatment that dropped the pressure by 5 points would reduce the risk to 31%. So you can see the higher your risk, the more important it is to get the pressure down and keep it down consistently. If we sort of cone out a little bit to the societal question, the prevalence of glaucoma in America is roughly 1 to 2% of people. The risk of blindness from glaucoma over a person's lifetime in some studies has been considered to be at about 5% of those with glaucoma. Those numbers get very complicated. However, if you already have glaucoma and you're followed for 20 years, your risk of winding up blind in one eye, legally blind from glaucoma, is about 25%. That's a lot of numbers, but the point I'm making is that looking at general numbers of risk, my risk of getting a glaucoma of 1% doesn't tell me much if I already have glaucoma. In America, there are about 150,000 people who are blind in both eyes, legally blind from glaucoma. Applying that to our treatments and considering the risk of a treatment to the risk of your disease, the SLT, the laser trabeculoplasty, as came up earlier in Dr. Schwartz's discussion. Well, SLT typically lowers pressure about 5 points, give or take. So your risk of vision loss from SLT, in other words, how risky is it to actually have the procedure? What's the likelihood that that damages your eye seriously? Probably about 1 in 1,000. So that's a pretty easy choice. Extremely low risk, cuts the pressure 5 points, drops your relative risk by 50%. Gets more complicated when we talk about trabeculectomy. Trabeculectomy is extremely effective in lowering eye pressure. Most people wind up with pressures in the teens. Not everyone, but most. But there's about a 1% risk of severe vision loss with trabeculectomy. Well, is it worth taking a 1% risk? Well, that depends if, again, you're the person whose risk of getting worse from glaucoma was 5 out of 100, and so your cost of getting there is 1 out of 100, you're still ahead. On the other hand, if you're someone who has advanced glaucoma and the pressure is 30, your risk of getting worse might be very substantial, and cutting that risk in half might be much, much more important than a 1 in 100 risk. The problem, though, is it's easy for me to sit up here, since I don't have glaucoma, although I do have a family history, and talk dispassionately about relative risks. I'm not the one who's got to go under surgery. I'm not the one at risk of going blind. And when we consider risks for our own issues, sometimes we're not so dispassionate. There's a body of knowledge out there from psychology and some related fields showing that in general, when we as people look at risks, we tend to overestimate them in our own mind for spectacular risks. A good example of a spectacular risk, that's a plane crash into the dirt filmed on live TV. Okay? That's pretty spectacular. Everyone's killed. It's a true tragedy. And everyone has in their mind, I don't think I'm going on a plane this year. On the other hand, common activities like driving a car, we're so used to them that we underestimate the risk. I just told you that more than 30,000 Americans died in car crashes this year, and yet I'm going to drive home today, and the risk is really not going to cross my mind. Personified risks, if someone tells us a story, like on the news where they show a picture of the person who was killed and his family, that tends to make us consider the risk much more seriously than if we say there's a plane crash over northern Siberia and 300 people were killed. People don't like risks for things they can't control. So risks on the roller coaster are more scary for some people than risks windsurfing, where they have a sense that they're in control, and so of course I'm going to avoid running over that shark and dying. They may not be right about that, but that's the way we all think about it. And natural risks like being hit by lightning, we tend to underestimate those very much compared to man-made risks like the plane crash. There's another factor from this research I'd like to talk about, which is how we value gains and losses. It turns out that we don't value them equally. We care more about loss than we care about gain. So if you take a bunch of people and you show them a beer mug and you say, how much would you pay for the beer mug? There's going to be a range of answers, $2, $10, $5, and on average you're going to come out with something. Let's say about $5 for a nice mug. If you instead take a group of people, split them in half randomly, and give half of the people beer mugs, and you say to those folks who just were given this beer mug, how much would someone have to pay you to buy that mug from you? They'll say a number that's about twice as high as the other half of the people. If the other half of the people, you show them a mug, you say, how much would you pay for this mug? The number they come up will be half as much. Now, when you had the whole group together, a separate group, let's say they came out at $5. Well, the people who were given mugs, suddenly that mug is worth $10. And the other people, the mug's maybe worth $5. I don't have one, I don't need one. So loss is much worse for us than gain. Twofold. And we're risk averse. So if you take someone and you give them an even chance 50-50 gamble, you shouldn't really care, right? If you have $1 and you can gain $1 or lose $1 with a 50-50 shot, it's revenue neutral, 50-50, right? Who cares? But when you give people these scenarios and you say, I'm going to give you $1 and I'm going to give you a coin flip, are you willing to undergo a coin flip to win or lose $1? Again, they have to be offered $2 in order to be risking $1, which is not a very way to play the game of coin flip. Not a very smart way to play the coin flip game because you're going to lose a lot of money. So we are risk averse and we don't like loss. What does that mean? That means that since people are more comfortable with things that are known to them and seem natural, oddly enough, people are more comfortable with the concept of glaucoma blinding them, which is natural and seems sort of known to you. Hey, doc, I've had glaucoma 10 years. Then the idea of this new fangled trabeculectomy thing. That's new. I don't have control when I'm under the operating room drape. It's not natural, and it's perceived as a potential for loss. The idea of dropping my pressure from 20 to 15 is a bit of an esoteric gain, and so it's perceived as a potential to lose my vision. So all these things tend to make us more likely to take our chances against glaucoma than to take our chances with, say, treatments like trabeculectomy, laser treatment, or even eye drops, which can be correctly perceived as having their own risks. So I'll sum it up by saying risks can't always be quantified. It's pretty complex even when you try to quantify risks. I would be really cautious when you read tonight in the newspaper that holding your breath drops your risk of asphyxiation by 2%. Those sort of relative risk things that we see reported all the time are usually worthless. And individual and society biases really make it hard for us to be objective about anything that involves our own health or our own situation. The other thing that you can take up from this is the person who's really at risk in this situation is the guy who didn't wear his seatbelt, because he has a 50% greater chance of dying, right, than these two guys. These are the smart guys. That's his relative risk. Well, thanks very much. I appreciate your interest. I appreciate very much everyone coming out on a sunny afternoon. Very good.